Hi, welcome to the second episode of Shoulder Talks. Again, today we've got Emily Fiorini, who's my PA, and our guests this month from MCP, Riley and Jess. Welcome, everybody. So today we agreed to talk about adhesive capsulitis, and I really appreciate Jess tracking down that article by Neviser and Joe Hannafin. And we're going to cite that article in our conversation. I hope everybody reads it. I genuinely think that it's one of the best papers I've ever read, and it makes things so clear. And it takes something that I think is sometimes confusing for people, which, is common for the shoulder, where there's mixed diagnoses, and like sometimes it's this and sometimes that, and it just really nails down adhesive capsulitis to make it very clear. One of the things I noticed in the article is that it identifies adhesive capsulitis as a very specific thing, and it says that frozen shoulder can be used to refer to several different things. Did you guys catch that in the article? Is that something that you guys have heard before, like frozen shoulder being sort of a mishmash of several different things? So tell me, Emily, what have you heard called frozen shoulder that's not adhesive capsulitis?
Well, specifically, I've heard that people can get a frozen shoulder after surgery if they've kind of like kept their shoulder immobilized when they weren't supposed to, that it gets really stiff and it's hard for them to move it. And it's essentially, frozen, but that's more due to stiffness from lack of activity versus an actual inside the joint frozen, like an actual adhesive capsulitis. So it's more of a stiffness outside the joint.
Yeah, and me personally, I tend to reserve the term frozen shoulder for isolated idiopathic adhesive capsulitis, right? If you have a reason why your shoulder's stiff, like you said, with surgery, or if somebody had a fracture and they're immobilized, like there's all sorts of reasons where I'm like, no, I don't think so. Like, could you call it a frozen shoulder? Yes, but I think if I want to be clear with my terms, I want to be consistent in only calling adhesive capsulitis frozen shoulder. Okay, so let's start the presentation. And we'll go through some of these slides together. And again, thank you to Emily and Riley and Jess for helping out. So similar to when we talked about the biceps tendon problems, understanding the anatomy is going to be fundamental. So we'll start with that. We'll move to the pathology, how the pathology presents, how we treat it conservatively, and then in the rare cases that surgical intervention is needed for this problem, we'll talk about that as well. So the anatomy for this one is actually pretty simple. The inferior capsule, the synovium, and the rotator interval. So basically, the pocket around the ball and socket joint. That's how I explain it to the patients, right? So there's the rotator cuff outside of that pocket. There's the cartilage that coats the bone. So the humerus, the ball, has cartilage on it. The glenoid, the socket, has cartilage on it. The cartilage on the glenoid, on the socket, is surrounded by the labrum, which is the O-ring that's around the socket. And then basically everything else around that is the capsule. So it includes the rotator interval, which is the space between the subscapularis and the supraspinatus. It includes the entire inferior capsule, which is that hammock that's on the underside of the shoulder connecting the humerus to the glenoid. We see that and we release that when we're doing a shoulder replacement. So before we dislocate the shoulder out the back, you guys have seen me go underneath the inferior glenohumeral ligament, protect the axillary nerve, make sure we have twitches, and we release that inferior glenohumeral ligament. And that is thickened and fibrosed in arthritis, right? And we'll see when we look at the histology, and Joe Hannafin, did that great work on that, and presented that in the review article with Advisor, and we see that histology, that it's the same type of fibrosis that you see in other conditions, but in this case, it's not because the joint is broken down; it's because the capsule is inflamed. So all of these things are going to be part of that pocket. And this is that table that is outlined very, very clearly and very, very nicely in that paper. And what this basically boils down to is that those anatomic structures in the ball and socket joint get inflamed. And when they get inflamed, they get stiff. Eventually, the inflammation burns itself out and the stiffness persists. And eventually, the shoulder loosens up. And the natural history of adhesive capsulitis is thought to be that it's self-resolving. And if people don't have any treatment, eventually the shoulder thaws and gets better. Simplifying this table, we've got stage 1, which is basically someone coming in with a couple of weeks of pain and saying it hurts kind of right here, right at the deltoid insertion. And they're able to move, it just hurts. A lot of times they'll say, man, I'm really struggling with night pain. I'm having trouble. And that's kind of the early phases of adhesive capsulitis in the first couple weeks. Fairly soon after that, within 1, 2, maybe 3 months, they'll get severe constant pain, and they'll have a global loss of range of motion. Emily, do you happen to have the model in the room with you? We should have planned that ahead, but if you happen to have, that's awesome. That's awesome. What luck we have. So can you show us with that model that if someone tries to forward elevate and they have inflammation in this, so that forward elevation, and if there's inflammation at the center of rotation, right where the ball meets the socket, that's going to be limited. Same with external rotation. So show them external rotation, right? So if the patient's trying to externally rotate, the range of motion is going to be limited by inflammation at the center of rotation, and then internal rotation, right? So one of the things that we'll see in the office is that because the disease process is at the center of rotation, they won't be able to go up, they won't be able to go out, and they won't be able to go in. There's other things that will present themselves with limited range of motion, but it's only this and one other thing. What's the other thing that will cause people to have limited range of motion in all 3 planes of motion?
So the other common diagnosis would be glenohumeral joint arthritis. That would cause limitation.
And how would we distinguish between adhesive capsulitis and glenohumeral joint arthritis?
You need to look at their x-rays to see whether or not they have arthritis of their glenohumeral joint.
Bingo. So with this, they'll come in severe constant pain, and the patient will usually say, oh man, just for the last couple of months, it just keeps getting worse and worse. And eventually that progresses to, instead of a freezing shoulder, to a frozen shoulder, where, man, I can't move this thing at all. And eventually the pain starts to go away. It's hard to, at least it's hard for me to distinguish between stages 3 and 4. I think we'll talk a little bit about that in terms of how, identifying what stage people are in helps us with the treatment, but only to a certain extent, and we'll get to that in a minute. So from our website, this is the 3 phases again: freezing phase, frozen phase, thawing phase. Stage 1 is early freezing phase. Stage 2 is mid freezing phase. And as the shoulder is starting to get stiff, and is getting more and more painful. Stage 3 is once it has gotten as stiff as it's going to get and the inflammation has really burnt itself out. And stage 4 is when they, really have no pain and they're really starting to improve and going into that thawing phase. Do you guys have any questions about this? Is this pretty clear? So you guys have seen how these people present. They come in. Sometimes they say, oh, I fell, but I didn't really have very much pain until a couple days later. Then, I was trying to take it easy, but, it started getting worse and worse. And what you'll see is the more careful somebody is with this, the more likely they're going to get a frozen shoulder, right? The people that are like, oh, it's fine, I'm going to work through it. So people that are manual laborers, people that, don't really have the luxury of resting their shoulders tend not to get frozen shoulders. And one of the things that they mentioned in the article was that people with sedentary jobs are the ones that are likely to get it because they both have the luxury and they're sometimes careful people. They're like, oh, I don't want to hurt myself, so I'm going to take it easy. And the more they take it easy, the more they protect themselves, the more and inflammation they get. So insidious onset of gradually increasing pain, severe night pain in any position. And again, we talked about that global loss of active and passive range of motion. So even if you try to help them, they can't go out. Even if you gently try to externally rotate them, they can't go, and they can't really usually get past the posterior ilium. We'll get an x-ray to make sure that they don't have arthritis. And once we've done so, we say, hey, listen, you've got a frozen shoulder, and this usually goes away, and we're going to help you along. If someone's really early on, like if it's like the first couple weeks, sometimes, even though I know the paper says anti-inflammatories don't really work, they have been shown to work, but I usually tell people, listen, it's only been like a week or two. We can try a meloxicam, we can try an naproxen, we can try to go to therapy and get some stretching exercises. And maybe we've caught it early enough that you are able to bounce back from this without getting an injection. But I will see them back soon after that, like sometimes 2 weeks, sometimes 3 weeks, but no more than a month after. Why do I, and you guys know, I'm not like aggressive, like, oh, we got to treat, we got to stamp out disease. We'll let people declare themselves. But why is adhesive capsulitis something where we really want to intervene early with the cortisone injection?
When you give the cortisone injection, it stops that inflammation phase. So you want to give that before they progress to the frozen phase. You want to give it while they're still in the freezing phase.
Absolutely. And what's the difference between this and other disease processes where we give cortisone injections? In the other cases, there's always, some kind of damage. There's another problem with the shoulder, right? There's a problem with the shoulder that causes inflammation. So we're treating the symptom, but not the disease. In this case, the underlying problem is the inflammation, right? So if we're treating the inflammation, we're treating the actual disease, right? It changes the natural history and it changes the course of the disease. And one thing that, I sometimes draw for people, like if they're, inclined to want to understand more, sometimes I'll draw this graph for them and I'll tell them, you're kind of over here, you're on the upswing of this freezing phase. What we're doing with the cortisone injection is we're flattening this curve sooner, right? We're bringing you out of the freezing phase into the frozen phase sooner. And one thing that you'll see when we give somebody an ultrasound guided glomerular joint injection is it actually helps us to distinguish stage 2 from stage 3. So think about it. How does it do that? How does the ultrasound guided injection help us to distinguish between stages 2 and 3? Like we have a guess.
Well,
right? Sorry, go ahead, Emily.
Oh, yeah, no. So if they're in stage 2, which is still the freezing phase, and you give them an injection, it should actually eliminate a lot of their pain and bring back a lot of their range of motion. Whereas if they're already frozen and the inflammation is not quite as, as hot as it was in phase 2 or stage 2, then it's not going to have as big of an effect. giving them an injection at stage 3.
And that's why if someone tells me they don't have very much pain and their pain has started to improve, sometimes I'll tell them, listen, I don't think you really need the cortisone injection. I think you might do just fine with the physical therapy if you're willing to try it, right? And sometimes they're like, no, absolutely not. Like, just give me the injection. Less pain is better. But you will see that even in the office, not even with the cortisone component of the injection, but even with the lidocaine component of the injection, you can kind of see where people are on that curve, because as they're starting to ascend that curve of increasing inflammation and increasing stiffness, when you give them the lidocaine component, they're immediately able to raise their arm more. How much more depends how far up that curve they are. And I think that it's actually predictive, where you give them the injection in the office and they're like, wow, that's amazing. I can't believe. I would say that person is more likely to be an early freezing phase, like a more of a stage 2. And once the cortisone kicks in after a week, they're really not going to have to work very hard with physical therapy. But if they're high up on the curve and you give them the injection, they'll say, yeah, the pain is better, but it's still pretty stuck, right? Those people are going to have to work pretty hard with physical therapy. They have to do a lot of stretching exercises because they're so late in the process that they've had to, some of that fibrosis. And, again, I highly, highly recommend everybody read that article by Neviser and Hannafin. I think it's an excellent article, and it tells you exactly what's happening, and it shows you the biopsies that they took early on in the disease process that show inflammation, and the biopsies that they took late in the process that show fibrosis. So it's really helpful to understand exactly what's going on at a cellular level, at a tissue level, because that translates into knowing what to do for the disease process on the clinical level. So the injection that we give is 8 cc's of lidocaine and 2 cc's of 40 milligrams per cc of Kenalog, total of 80 milligrams of Kenalog. And if someone's too early on, then it might not be needed. And if someone's too late on, it might not be needed. The perfect timing for that injection is someone who's had severe symptoms for somewhere between 4 and 6 weeks, because it's declared itself like this thing's not going away. It's not, something that the patient can ignore, but it's early on enough that hasn't started yet doing that fibrosis and knocking them out of the freezing phase before they get late enough into the frozen phase. That makes sense? Cool. All right, and then surgical treatment. You guys have been with me for long enough to know that surgical treatment is going to be something that's a last resort for most things, and especially for this, right? If something, the natural history is resolution, even if you ignore it completely, and what we're doing is making things get better faster, then it tends to be something that most people will get better. And a lot of the times the 2-month follow-up after the Glenhumeral joint injection, people are so happy. They're like, oh man, this is awesome. And they're still doing their stretches. If they do fail conservative management, we put them under anesthesia. We examine them first. I did have one lady who had a clinical diagnosis of adhesive capsulitis that failed conservative management, and she went under anesthesia, and she had full passive range of motion under anesthesia. That's not adhesive capsulitis, right? Like that's something else. Like, yes, she has pain. No, she didn't get better with the conservative management, but there's nothing that I would do surgically to go in there and release anything, because she's got full passive range of motion. Most people, even under anesthesia, their shoulder's completely stuck in the same way that it was in the office. We go in there arthroscopically. We release the inferior glenohumeral ligament. We resect the rotator interval. We look outside the shoulder. If there's any sort of adhesive bursitis or any adhesions on the outside of the shoulder, we release those. And then with very gentle manipulation, the shoulder is able to regain full passive motion. They'll start physical therapy the day after the operation, and they'll work on their stretching. on their own. So I think that, it's really not a super complicated problem, but I do think that it's easy to miss. And especially when people are coming in and like, oh my God, I have severe pain. I can't sleep and I can't do anything. You know, sometimes it's like, okay, I don't really know what's going on. And I think being attentive to this problem and being aware that this is actually a very common problem and a very treatable problem helps us to catch it early before people get into the frozen phase. So in terms of pearls, what are your observations? What do you guys think is helpful to know about this problem?
Well, I think one thing is just making sure that you are not just taking someone's clinical exam into account for this condition, and that you are looking at the x-rays. You don't want to misdiagnose somebody with either adhesive capsulitis or vice versa with glenohumeral joint arthritis. So, while the exam might be very obvious because they can't move their shoulder, you want to make sure that you're not forgetting something, especially when people are in that age range where they're kind of between like the older population versus the younger population, because it is typically more of a younger person's disease, where arthritis is more of the older population's disease. So you want to make sure that you're taking everything into account with this. I say is one of the bigger things to keep in mind. And also making sure that somebody's actually unable to really move their shoulder. They're not just afraid to move their shoulder because it hurts, because true lack of range of motion because it's truly frozen is different than lack of range of motion because somebody's afraid to push through the pain. So, as much as it kind of stinks as a clinician to put people into those painful situations, you really need to get the best exam possible.
That's awesome. I agree. So what do you guys think is the one thing that people are likely missing, or what is the one physical exam finding that is so helpful in identifying adhesive capsulitis and or glenohumeral joint arthritis that you're not going to see with anything else? Like it's not necessarily pathognomonic, but if it's something that if you're attentive to and you're disciplined about seeking out with people with severely painful shoulders, you'll be able to compare people side to side and be like, oh yeah, no, this is something that I know at least helps me identify where your inflammation is and where your pain is likely coming from. What's the one physical exam finding that's going to be fairly specific and fairly sensitive for identifying inflammation at the center of rotation of the ball and socket joint?
The limitation in the range of motion will be in all planes. So front elevation, external rotation, and internal rotation will all be limited.
And which one of those is the one that's likely to be normal for somebody with a different shoulder problem? Like, let's say somebody with a rotator cuff tear. What are they likely going to have that's normal that would be abnormal in this case?
Their external rotation, because they can activate other muscles to get their arm when either they can lift their arm up away from their side and activate other muscles, or even with it elbow still at their side, they can still activate other muscles to get some degree of external rotation. But with adhesive capsulitis, their external rotation is going to be really limited.
And even if it's not their muscles, right? Like even if, let's say they have profound external rotation weakness, right? Like they have a huge rotator cuff tear, very, very, very painful, right? So you ask them to forward elevate, they're like, no, I can't. And you're like, what if I help you? No, please don't do that. Okay. They have a huge, massive rotator cuff tear. Can you externally rotate? No, I can't, right? But passively, they're going to be able to, right? You're going to be able to passively bring their arm away from their body. This is not going to be something that's limited on somebody with a rotator cuff tear. Yes, they might have an external rotation lag sign, right? They might let you bring them there and you say, can you hold it there? And they say, no, please don't let go, right? And if you say, okay, I'm gently, and like even like gently trying to let go a little bit, their arm comes back and they're like, oh man, that really hurts, right? So their passive external rotation is going to be symmetric for a rotator cuff tear and for really any other problem. But with adhesive capsulitis and glenohumeral joint arthritis, they don't have passive external rotation. You can, like Emily said, like, listen, I know it hurts, but let's go slow, let's go real gentle. And you put one hand on their elbow and one hand on their wrist, and you gently say, okay, let's go real slow. And you try, there's a stop there. Like you cannot passively externally rotate them, usually more than like 30 degrees or so. And I think if we're attentive to that one thing, I think it simplifies things quite a bit. And identifying people that are stiff, that have loss of active and passive forward elevation, loss of active and passive external rotation, loss of active and passive internal rotation, then we say, okay, I'm confident this is a stiff shoulder. And if it's idiopathic and if they have a normal x-ray, then we can confidently say, hey, I think these are people with adhesive capsulitis, and it puts us on a path of treatment that is usually, I think, pretty successful. Cool? Questions, guys? All righty. Thank you, guys. Till next time.